Good morning, everyone. Mark Crowther here. We will just give people a moment to join. It will take a minute for everybody to be logged in. And for those of you at St. Joe's in the Miller Amphitheater, I will, your chat function should be on, but I will also promote you in 1 minute once the number of attendees settles. So we'll just take another 15 or so seconds to let Zoom bring people across, and then we'll get started. All right, excellent. Looks like numbers are pretty good. I'm Mark Crowther, Chair of the Department of Medicine. I think everybody knows who I am. This is the last set of Chairs Grand Rounds for the calendar year of 2021, a year yet again of some excitement for many different reasons. Welcome to the world of Omicron. These are recorded, and this will be posted on our YouTube channel as per our usual habits. And as per our usual chat habits, if you have questions, please put them in the question and answer box. We have the chat function open with some limited functionality because some people, because of the version of Zoom they have, they cannot access the question and answer box. I will moderate the question and answers, and we will have time at the end of the presentation, I hope, for a good discussion. So I look forward to a great talk. Today's speaker, I think probably most of the audience knows, is Dr. Sean Wharton. Sean was a resident in internal medicine at McMaster, graduating in 2005. He's had a really interesting career since then. He is a part-time faculty member here at McMaster. He's a faculty member in Toronto, has done a ton of really important work on anti-Black racism and other issues. But of most interest to me, as many of you know, is that Sean has become an extraordinarily successful researcher and clinician in obesity and runs four Wharton clinics located in southern Ontario. That have just been a huge success. And I know that because of many of my patients attend those clinics and have done really well with them. So I've admired Sean's work in that area for a long time because that's a tough area to work in. And we asked Sean if he could do rounds today on an interesting combined topic, which is racism and obesity, because there's some parallels in those areas. So without further discussion, I will turn it over to Sean, and I look forward to a great presentation. Sean, please go ahead.
Terrific. Thank you very much, Mark. This is exciting to be here. And I thank everybody for joining me for this grand rounds entitled Racism and Obesity Bias in Medicine, Similarities and the Challenges. So for our land acknowledgement, McMaster University recognizes and acknowledges that it's located on the traditional territories of the Mississauga and the Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. Here are my faculty disclosures and mitigations. The talk on obesity has conflicts of interest noted here. These will be mitigated by addressing research and academic studies. And the talk on racism in medicine has no conflicts. So here are the objectives of my talk today. At the end of this presentation, participants should be able to, 1, describe bias and prejudice and its effect on medical care, 2, take steps towards minimizing bias within their practice, and 3, identify systemic racism within society and also within medicine. This talk will focus on both obesity and also racism. I see the injustices to people living with obesity every day in my practice. And I see the similarities and challenges in regards to anti-Black racism. But let's be clear, obesity and racism injustices are not the same. You don't get shot for having obesity, there was no slavery, and there are clear effective treatments for obesity, whereas a fix for systemic racism is very hard to come by. So this presentation is not to put anti-Black racism and obesity bias on the same level, but to call out injustices in each area. I'll spend about 1/3 of my time on obesity medicine and the bulk of the talk on anti-Black racism within medicine. Throughout this talk, I'll stop for calls to action. I'd like us to leave with actionable steps and not just contemplation. I'll first talk about bias in obesity. In my residency program at McMaster around the 2004 range, I was already quite interested in hypertension in Black people and the inequities within care. I then encountered Dr. Arya Sharma, a nephrologist, who was also interested in hypertension, but more so with the connection to obesity. I started to work in obesity medicine, and very soon into my journey of obesity research, it became very clear to me that much of our lack of understanding of obesity was mainly due to bias against people living with obesity. We know that the inflammation caused by the white adipose tissue causes a significant number of medical conditions, ranging from cognitive decline to metabolic conditions and cancers, even acute conditions such as COVID-19 are significantly worsened by this inflammation. So why would such a prevalent, devastating disease go understudied and untreated and frankly disregarded? It's because of obesity bias and discrimination against people living with obesity. We'll be talking a lot about bias, so let's define it. If you Google it now, bias, the definition comes up as prejudice in favor of one thing, person, or group compared with another, usually in a way that is considered to be unfair. Obesity bias is negative attitudes and views about obesity and about people living with obesity. Let's look at the definition of implicit and explicit bias. Implicit is the unconscious bias, and explicit is conscious bias. Implicit bias is the most common and possibly the most dangerous, as it is not obvious. If you want to know, do I have implicit bias? You can take the implicit bias association test from Harvard. You can Google it and do it online for free. You can test for many biases such as weight, race, gender, and sexuality. So here's the thing about obesity bias. Almost everybody has this bias. So how can I be so sure of this fact? Studies show that obesity bias starts in preschool. If you show a picture to children in preschool of a child living with obesity versus a child with a disability, the preschooler will never choose the child with elevated weight as a playmate. They also start to assign negative attributes to those with obesity, including laziness, a lack of intellect, and other harmful traits. This bias continues well past preschool and is seen in doctors and healthcare providers. 70% of people with overweight and obesity say that they experience stigma from healthcare providers. This is certainly a staggering number, and we know that this can be quite overt at times. The call to action here is to recognize that you may have weight bias or obesity bias. Since bias, stigma, and discrimination is the major problem within this field, we decided to write the guidelines along with patients that kept an eye out for our biases. They told us that we, the researchers, were biased. We took this message to heart and worked to ensure that each chapter was not biased or stigmatizing. Over 3 years, 62 authors wrote the new Obesity Guidelines, published in the CMAJ August 2020. These guidelines have had an impact in Canada and around the world. The guidelines were the #1 most read article in the CMAJ in 2020. We believe this is likely due to the focus on obesity, bias, stigma, and also discrimination. I'd like to give you a clear example of bias and discrimination from a family doctor here in Canada. This piece was written in the Medical Post, August 2020, shortly after the release of the guidelines. The doctor states that losing weight is too hard because the general attitude of patients coming into her clinic is one of non-accountability. Not that there's a biological or genetic reason for elevated weight, but mainly blaming and shaming them and stating that they are not accountable. She also goes on to state that when she inquires about their diet, they're incensed when she tells them that pierogies are not a good choice. She suggests that we should paint billboards with simple common sense information to help these patients. This is a clear example of explicit bias leading to discrimination. After dealing with weight biases of healthcare providers, we now have to battle the issue of internalized weight bias. This is also a challenge. This is always a challenging topic to actually talk about, as it is so disheartening as society's biases has led to this internalization. People living with obesity hear all the same messages, see all the same stigmatizing pictures, hear all the same jokes, and believe that they themselves have a character flaw and they don't deserve care. The primary solution here is for healthcare providers to have patience and compassion. You may not change your patient's mind right away, that internalized bias is intense, so be patient with them and compassionate. Let's discuss stigma, often the reinforcer of obesity bias. If you Google obesity and images right now, in fact, why don't we do it? Everyone's on the computer. So I want you to, let's say you're going to do a PowerPoint presentation, and you want a man living with obesity in the presentation. So if you put into Google, man, obesity, and images, let's see what you find. Real life example right now. Let's see what you find. What you'll find is that 72% of the images stigmatize people living with obesity, and that's a real shame. Images of people wearing clothes that are too small for them, riding up their bellies as if people don't know how to dress, or images of them in unflattering positions. You wouldn't want any of these people as your doctor, as they don't look like lawyers, they don't look like professionals, they don't look like people in society that you'd want to associate with. And that's just all stigmatizing or stereotyping images. This is hurtful, it's belittling, and it should stop. Instead of these images, Obesity Canada has an image bank where they're free, and these images are free, and they're images of people living with obesity who are active, moving, dressed in appropriate fashion. These are the images that should be displayed. Clearly, the biggest challenge facing obesity is a lack of knowledge within the medical field regarding the science of the biology of obesity. This lack of knowledge leads to recommendations such as eat less and exercise more. This simplistic message does not address the biology of obesity, and as a result, it does not work as a treatment. Obesity is a disease that lives in the brain. The three areas of the brain most involved are the mesolimbic system, that's the hedonistic part, the hypothalamus, and that's the homeostatic part, and the frontal lobe, the executive part. All mechanisms of the brain are designed to drive weight up and to encourage a regain of weight if there's ever an attempt to lose weight. The intensity of these systems to protect against weight loss is driven by genetic factors, coding for receptors and neurochemicals that promote weight gain. We're gaining a greater understanding of the brain, therefore we can develop treatments that actually work. The three interventions that work, these three interventions, psychological intervention, pharmacotherapy, and bariatric surgery, all work within the brain neurochemistry and support medical nutrition therapy or diets and physical activity. We have moved away from talking about diets in favor of talking about medical nutrition therapy. It is very clear that any decrease in calories triggers neurochemicals that drive weight regain. We now discuss healthy eating parameters or medical nutrition therapy. The guideline makes recommendations based on evidence for specific dietary interventions for medical conditions, such as, because this word, medical nutrition therapy, it's new to a lot of people, so what does it really mean? So it's easy to understand. Really, if you look at hypertension, we've got a nutrition that is good for hypertension. What's it called? The DASH diet, everybody knows that. Heart disease, what dietary approach? Mediterranean. Elevated blood sugars, lower carbs. So these dietary approaches are all recommended when treating those specific conditions, but there is no single specific dietary intervention for treating obesity. This is super important. There's no single dietary approach for treating obesity. Just having a better and healthy diet is what actually works. Pharmacotherapy is the scalable, game-changing option for obesity management. Just like with hypertension and heart disease, medications changed the playing field. There are approved medications here in Canada, and there are emerging medications. Just last week, Thursday, Health Canada approved a game-changing treatment, a once-weekly GLP-1 analog at a dose that is truly effective for weight management. This field is rapidly changing, and it is an exciting time. We developed the 5 A's as a bit of an easy way to understand the journey through obesity management. I will emphasize that the most important part of the 5A is the ask. That asking the patient for permission to discuss obesity management is crucial to gaining trust with the patient, as it has been lost for years due to discrimination within the healthcare field. The healthcare provider should also ask if they can discuss options above and beyond diet and exercise, as this will be the important aspect of effective treatment. I want to end this section on obesity management with a real live case. Last month, I was working in internal medicine at the Juravinski. I saw a patient in the emergency department. This is not a picture of her. This is just a representation. She'd come in for a COPD exacerbation. She'd never seen a respirologist. She was not vaccinated. And I could tell that she was around 350 pounds, BMI in the mid-50s, clearly living with obesity. The COPD part was bread and butter, internal medicine, fix her up, all good. The challenging part was, why was she sad? And had anyone talked to her seriously about her obesity or about her COPD? Well, I did. At this point, I'd been in the room for maybe three minutes. And I say to her, Jane, have you been referred to respirologists ever? No, I haven't, and I don't know that it will really help. Well, Jane, I think it can really help, and I think you are worth it. Jane, has anyone talked to you about your weight? No, not really. They've said that I should just lose weight, but no real help. Well, Jane, there's good news. There are very effective treatments now, and again, you are worth it. People love you. Would you like me to help you coordinate that? Yes and yes, she said. Thank you. This was the first time someone had ever talked to her about it. She was tearful, but very focused, very understanding. She understood that this was the right time with somebody talking to her and asking her permission to talk about it. So she got vaccinated in hospital, both COVID and her flu vaccine. She was discharged with a referral to a respirologist and a referral for bariatric surgery. I also gave her a script for GLP-1 analog for her to fill as an outpatient because she was worth it. So the call to action here is to recognize your own weight bias. If you've not treated patients living with obesity with medications, surgery, or CBT, then you may have weight bias, because goodness knows you have a lot of patients with obesity in your practice. You'll see them all today. Eliminate stigmatizing images. They may reinforce biases and discrimination. Gain a better understanding of the biology of obesity, its neuroscience, and our treatments need to follow these biological principles. Put standard guidelines and treatments in place to change the course of this disease and to treat patients with compassion and empathy. Now let's discuss my other passion. It's time to dismantle anti-Black racism in medicine within Canada. This is the title of Dr. Norm's recent commentary in the CMAJ. It's a powerful message, and it is time. This is a picture of my wife and baby James. James just turned 1. I am passionate about this field because I'm going to do everything I can to have James grow up in a world where he can have the same advantages, make the same mistakes, and live an equitable life similar to those around him. I know this is a bit of a pipe dream, but it's worth fighting for. I want to start with a quote from James Baldwin. He was a writer and activist in the 60s and 70s that put pen to paper about how we feel as Black people. Here's his most famous quote. Not everything that is faced can be changed, but nothing can be changed until it's faced. And that is what we have to do here and cover the systemic racism within medicine and actually face it. Let's look at the definition of racism. Racism is defined as any prejudice against someone because of their race. But if we leave it there, we only deal with overt racism. Actually, I've got to pause a second because I forgot to plug in my computer. Hang on.
Just while we're waiting for Sean to plug in, don't forget that if you don't want to ask questions, just put them in the question and answer box, and we will deal with them at the end of the talk. And if Sean disappears because his battery dies, we'll get him back on quickly.
I made it back. That's so funny and embarrassing, but here I am. So you always have to have some glitch to make your presentation memorable. There it is, guys. So again, let's look at the definition of racism. Racism is defined as any prejudice against somebody because of their race, but if we leave it there, we only deal with overt racism. The real issue is a racism that most of the world practices every day, and that is systemic racism. So racism should be defined as any prejudice against someone because of their race when those views are reinforced by systems of power. So who in Canada faces anti-Black racism? 3.5% of Canada is Black. We're the third largest visible minority, and there are 4.7% Black Canadians within Ontario. When we think of racism, we often think of overt acts of racism, such as lynching, the actions of the Ku Klux Klan, or slavery. But Canadians are often smug, stating that there is no racism here, we don't do these things. Well, there is racism in Canada, and there was slavery here in in Canada also. Lessons for another day. Let's talk about what's happening now, today. In my view, police brutality is overt racism against Black, Indigenous, and people of color. This treatment is not subtle, it's extreme, precise, in the acts of an organization steeped in systemic racism, meaning the ethnic background of the police officer does not matter. The report by the Ontario Human Rights Commission in 2020 is clear. Blacks are 20 times more likely to be shot dead in Toronto by the police. The statements by many police chiefs are clear, stating that there is racism in the structure of their organizations. The need for reform is being realized in jurisdictions all across the US and within Canada. This is no longer a question, is there racism, systemic racism in the policing force? It's a reality that cannot be ignored, and there has to be change. So systemic racism lives in Canada. And here's the thing, the system works with or without you. Systemic racism doesn't mean that there's lots of racists in the system. It means that even if there were zero racists present, the system would still disproportionately harm people of certain races. It is a machine that runs whether we pull the levers or not. Just by letting it be, we are responsible for what it produces. Therefore, action is actually needed. So why are you listening today? To learn how to recognize overt racist acts, or to recognize systemic racism that threatens the progress of people of color within Canada. The problem that handcuffs us in Canada is that we collect very little data by race or ethnic background. We don't collect university admission rates, home ownership rates, infant and maternal mortality rates. This is all data regularly tracked by the US governmental agencies. Historically, this was done due to the fact that Black slaves were property and had to be accounted for. Yet if we collected this data, it would enable us to more clearly identify and intervene to dismantle the primary barriers impacting Canada's Black population. To understand why there's anti-Black racism in healthcare, we need to better understand that the implicit bias I was discussing earlier. Our brain needs to make associations every minute by integrating data and grouping it. That's survival. These associations are mainly unconscious or implicit, and they can be created and also taught. For example, if you see a nun and you're told the associated words are good, angelic, kind, non-threatening, that's what your association is. If you see a Black man and you're told thug, gangster, your association is again clear. You're now treating both of them in the emergency department for shortness of breath. You may give the nun lots of time and good treatment. The Black male, you may cut him off short and ask, well, do you smoke? This barrage of stereotypes creates external bias and internal bias. Here's a classic study on racialized internalized bias. It's called the Dahl test. The study, published in 1950 in the Journal of Negro Education, shows that by age 5, Black children already internalize the biases against them. When Black children were asked to show the instructor the good doll, it was the white doll that they pointed to. And when asked to show the bad doll, it was the Black doll that they pointed to. This research is hard to swallow, but it is clear. Humans internalize bias at an early age, and the Black and I'm Proud movements in the 1970s weren't for the outside world, but instead our own people. Let's look at some studies that document this implicit bias within medicine. This is a study done in 1999 by Kevin Schulman, looking at the effect of race and gender on referral for cardiac catheterization. These were all actors, white male, white female, Black male, Black female. They were all given the same script: crushing chest pain, radiating to the left arm, sweating, a sense of impending doom. The scenarios were shown to internal medicine doctors at a conference. They had to decide treatment of the patient. And these doctors were from all backgrounds. Here we can see that the white males were given the option of cardiac catheterization the most. If you were female or Black, the odds ratio was 0.6% chance of getting a cardiac cath. When looking at both race and gender, the differences were primarily driven by the fact that the Black female had a 0.4 odds ratio of being referred for cardiac cath. Black females got the short end of the stick for no other reason besides implicit bias against Black females. Well, that was a long time ago, in 1999. Things may be different now. A 2019 study looked at 4 million records of patients that got a angioplasty to see who got it late versus early, adjusting for confounding factors. The earlier you get plasty done, the more cardiac muscle you can actually save. The data showed that the factors that determine a late angioplasty were female gender, Black race, weekend admission, and private insurance. In other words, being female was as bad as not having insurance. Being Black was as bad as not having insurance. But being Black and female was again the double whammy. It appears that things have not changed, particularly for Black women. What about here within Canada? Dr. Norm and Dr. Lofters here show that Black women may be underscreened for cervical and breast cancer and may be more predisposed to worse outcomes. Remembering that here in Canada, we do not collect data appropriately to be able to understand a lot of these challenges. I've researched this disparity within obesity medicine as well, because in my clinic, I collect the data on racialized groups, on ethnic background. As soon as I started my clinic, I knew that research within this field was an important aspect. We looked at the results of weight management at my community-based clinic in over 9,000 patients. We found that overall, women of color lost less weight than white women did. When we adjusted for the number of visits to the clinic, there was no difference. So the issue was access to care. We could not reach them, they could not reach us. The system was not built for them, but for those with privilege. We've been working on solutions to correct this by starting to use virtual care and virtual medicine well before the pandemic to reach women in their homes and also at work, and also having weekend clinics. COVID has brought systemic racism to light in Canada and in the US. Those most affected by the virus are the marginalized groups, Indigenous and Black people. Early in the COVID pandemic, it was estimated that 21% of those affected by COVID are from the Black community, while Black people make up 9% of the population here in Toronto. This disproportionate representation is likely due to systemic biases, including the fact that many minorities work in essential labor services and cannot work from home. Also, the systemic biases in healthcare, which lead to poor health and higher risk and a lack of access to care. This recent publication by Kwame Mackenzie documented the cases of COVID from June to December 2020 in regards to racialized group in Toronto. Researchers advocated for the government to collect racialized data, and this was allowed for one of the first times within Canada. These ratios are in proportion to the white population. It was the Latino population trial that fared the worst, while the Black population initially did quite poorly, up to 9 times higher rates than the white population, and then somewhat improved, but still we're at 2 times the rate for contracting COVID compared to whites in Toronto. Documenting COVID according to racialized groups allowed public health to focus vaccination efforts in places and in groups with the highest rates. This is a clear example of how important collecting racialized and ethnic data is. To try and correct the implicit bias within medicine, would physician diversity actually matter? This study looked at this question. They asked Black men, who were the patients, to see doctors from various ethnic backgrounds, a Black doctor, a white doctor, or an Asian doctor. All doctors were instructed to give the patients advice on preventative care, the flu shots, healthy eating, etc. The study found that Black men were more likely to follow the recommendation of the Black physician. The advice here may be more valued. There is a Black-white gap in cardiovascular mortality in men in America. This study suggests that this better care could reduce that gap by 19%. They looked at the notes from doctors. The non-Black doctors wrote very short notes, 1-word notes often, weight loss or anxiety, whereas notes from the Black physician were longer, they're more detailed, needs food, shelter, clothing, and a job. Patient yelled at me, but agreed to get a flu shot because I recommended it. Made patient laugh. You can see that there's likely a different relationship occurring with the physician and their patient here. To that end, how do we address increasing the number of Black physicians within the system? The suggestion is to address the leaky pipeline within the education system. The idea of the leaky pipeline is that we're losing quality Black students at an alarming rate, often due to systemic racism within education. Examples are Canada's most well-funded schools exist predominantly in non-Black neighborhoods. The gap between Black and non-Black student achievement is growing, and there's evidence that much of that is steeped in anti-Black racism. From the 2017-2018 Toronto District School Board report shows that 34%, one third of all students who were expelled from the Toronto District School Board were Black. Black students only made up 11% of the Toronto District School Board. The school board executive stated that systemic factors of race and poverty find their way into the school system and factors into these expulsions. We have to start addressing the power and privilege and the bias within the system. And those were his statements as a school board member. So what are the solutions here? There's no single solution that can undo hundreds of years of racism, and solutions will need to come from a wide range of places, organizations, and individuals. I've been told to make a good presentation, you have to tell stories. So I'm going to tell a story about how I made it to medical school and started the BMSA as an example of a solution. I'm an immigrant of South America, British Guyana, an impoverished British colony, part of the West Indies and the African slave trade. It's often funny to me to realize that most people are unaware that most Black people without an African name got their last name from their slave master. We were from the Wharton plantation from the late 1800s, originally in Barbados. My dad trained as a physiotherapist in London, England, and then we immigrated to Canada in the 1970s for a better life. Unfortunately, my parents split up shortly after we arrived here within Canada. A very amicable split. My father stayed in our lives and was a big part of our education. But to raise 3 children in a new country was not easy. So we had to go on welfare and move into the projects. My dad's meager income could not help much. We stayed on welfare for 5 years while my mother went to school and got a Bachelor of Science degree and then went on to Teachers College. Those years were actually great. We had lots of great friends and we excelled in school and also sports. So here's my privilege. My parents' families are highly academic, and our welfare house was like a little university in the projects. Things were good for us and we got lucky, but life was different for some of those that were bright and capable, but got left behind. I graduated from pharmacy at the University of Toronto. I was the only Black student in my class of 170. This was disappointing. I practiced for a while as a pediatric pharmacist, then I did my doctorate in pharmacy, and then finally moved on to medical school at the University of Toronto. Upon entering U of T medicine, it was frustrating again to be one of only 3 Black students out of 270, 1% of the class. I jumped right into activism. The first challenge was tuition deregulation, which meant the fees were going up from $5,000 a year to $25,000 a year. Of course, we knew who that would affect the most, racialized groups. Quote in the newspaper was, students fear that the medical profession will be reserved for the rich, excluding marginalized groups. As VP of the student union, we organized marches with our allies. We lost the battle, but it was a good fight. I then turned my attention back to the issue of underrepresentation of Black medical students. I started the BMSA in the year 2000. This was my 3rd year, along with the other students from the other years. We were 8 in total out of 1,080 students. The mission of the BMSA was to engage with undergraduate students and mentor them for entry into medical school. We also wanted to provide support to the few that we had within medical school. We had success in increasing the number of Black medical students, and we stayed strong for 20 years. Each year, another group, often small, from 1 to 6, would do the hard work and reach out to the undergrads. It's now 21 years, in fact. We did have some fun. Here we are looking like the Temptations or the Pips. Over the years, we've seen the development of programs designed to reach the goals that the BMSA had the audacity to dream of. Thanks to Ike Okafor, who started the community of support to address mentorship and offer guidance. We were also fortunate to see the work of Dr. Lisa Robinson, Associate Dean at the University of Toronto, for spearheading the Black Student Application Program. The Black Student Application Program encourages members of the Black community to be part of the file review and interview process. These are Black physicians, professionals, scholars, and members of the broader community. So why are they at the interview process? While there's a recognition that a lack of diversity and inclusion will continue within medical school and other professions when visible minority leaders are not present at the table. Here are some of the results. U of T Medical School went from 1 student in the class of 2020, Chika Ahuru, also the class valedictorian, and now there are 25 students in the class of 2024. I'm proud of starting the BMSA 20 years ago, and has now grown from just U of T to across Canada. Here's the picture of the inaugural national meeting of the BMSA. What about McMaster? In Hamilton, 3.3% of the population is actually identified as Black, representing the second largest racialized group within Hamilton. Yet most years, there's approximately 0 to 2 Black medical students in McMaster undergraduate medical school, cohorts of over 200. This is representing 1% or less of students. Dr. Audrey Campbell, chair of the Diversity and the Engagement Committee, and Dr. Jason Profetto, chair of Clinical Skills and the MD Admission Program, both in the Department of Family Medicine here at McMaster, have helped to create the Black Applicant Equity Initiative for medical school at MAC. It will have similarities to the Indigenous Application Equity Initiatives. So far, it has passed 4 of the 6 steps towards being approved. Some highlights that I got directly from Dr. Profetto are here. Black equity in admissions has been deemed a priority for McMaster, and hence the work that has been done to date. Admission is the first step to the longitudinal process of structural support for Black students in our program to ensure and optimize success. This program was created and formed with extensive consultation from our Black physicians, residents, students, scholars, academics, and the community members. So what can we all do? Let's support the organizations that do this hard work, as it takes a village to get us to this goal. And so what can you do right now that is actionable? Accept that Canada has systemic racism within education, within healthcare, within the police force. Possible solutions. Let's work towards collecting race-based data within Canada. Implement programs that assist mentoring and recognition of diverse candidates. Support the organizations that do the work to dismantle anti-Black racism within Canada. In conclusion, we started the presentation with a discussion of weight bias. We know that weight and obesity bias in obesity medicine is real. It stalls research, treatment, and harms those with obesity. Stigma and stereotypes are hurtful and perpetuate implicit and explicit bias and prejudice. Anti-Black racism exists within healthcare in Canada, and there are solutions, and we can do better, and we should do better. And listen, I get it, this is fatiguing, but listening to so much of the anti-Black racism mantra over and over again. But if you're tired about hearing about racism, imagine how tired people are of experiencing it. Thank you. So As I said, James is just over 1 now. He's 14 months old. And my hope for him is a better life as a Black boy and eventually a Black man within today's world. Thank you very much for your time.
Thanks, Sean. That was great, really clear and really articulate, and very well done. Thank you so much. We've got quite a number of questions here. We're going to start actually. Herzl Gerstein wants to ask a question by voice, and so I'm going to allow him to talk, which may take a second to turn on. So Herzl, just give me a second. Yeah, you're live now. Herzl.
Okay.
A lot of background noise.
You can hear me? Yeah.
Yes.
Okay. Sean, totally. I've known you since you were a resident, and I've watched your career since 2000 and since the early 2000s, and I'm very impressed watching you on CBC and speaking, etc. So, fantastic presentation. I just want to maybe comment that the same sorts of things that you talked about, just with the obesity part first, the same sorts of things that you talked about with obesity, every one of those biases applies to diseases associated with obesity, and diabetes is the one that obviously I know the most about, and there's huge bias in diabetes. And I remember very well giving one of the internal medicine CME programs that happen annually, and I said that the most important thing to say to a patient with new diabetes is that this isn't your fault. After which an internist came up to me and yelled at me and said, of course it is. People cause their own diseases. They don't take care of themselves. And they say the same thing about obesity. And of course, 80% of people with diabetes are obese. In every randomized controlled trial that's been done in the last 15 years, the mean BMI is 31 and 30 of people with diabetes. So this is huge. And of course, there is obviously confounding, obesity and race obviously are confounded with each other. So I can't, I agree more with the importance of acknowledging it and understanding it, and not blaming our patients for being obese or for being or having diabetes or for being Black, for that matter. And the second question I have for you, I think the point about measurement is important. I mean, McMaster got its world reputation because it understood 40 years ago, 50 years ago, the importance of measuring things, and that's what the initial DME program was, etc. So having said that, do you know if race is now being put into Odyssey, the new EMR program that's being developed at HHS, and is it in St. Joe's as well?
That is a really important question, and I would love to see it, because I'm going to imagine that Odyssey was not a Canadian-based program, that the tech and the development was likely in the States and other places. So therefore, the ability to put in race has to be there. And what we've found out is that self-identified race is the best way. So if somebody identifies himself, because race is a social construct. What we mean by that, and people have challenges with the issue of social construct. It means that the biological differences that would cause a problem between a white and a Black person are so minimal that you can't even separate them. The big challenge is are you discriminated against? That's where and that's why it's a social construct, because it's all about the discrimination. So if you feel that you're discriminated against because your skin tone, because you're like I don't know, 90% white but 10% Black, and that's enough for you to be discriminated against, you feel it and you understand it, that's your identification, and that should be on the chart. It really frustrated me when I went down the States, when I'd go to the emergency department, or I'd be at rounds in the States, and back when I was younger, and they would say, 25-year-old Black male presents with a broken leg to the emergency department. I'm like, what does Black male have to do with presenting with a broken leg? It's a broken leg. Do you know what? In America, it has everything to do with what's going on. So that Black identification means so much for him and for the system and for everything. So that's why we should identify people and be able to fix things in the according fashion. I was very much against identification because I didn't understand. I wasn't woke. I didn't understand what racism was and systemic racism was. And now I do. And now I have a greater understanding, and I'm learning. But identification is important.
Thanks, Sean. Thanks, Herzl. I'll ask now, the Miller Amphitheater, I think, has a microphone. So I'll ask Madeline and or the people in the Miller if they have any questions.
Hi, Mark. Hi, Sean. Can you hear me?
Yes.
Okay, great. Sorry, we don't have the video on, but we've got a group of folks, and thank you for that phenomenal rounds.
Thank you.
So I can actually give you a small update, and I can tell you that behind the scenes, the Odyssey team is working together with the Dovetail team at St. Joe's on trying to develop a robust and consistent race-based data approach citywide. And that's being led by Drs. Clara Liu, by Dr. Aisheng Tago, and to Dr. Toby Olaya, who are three of our amazing trainees. So I had a question for you on that, because we've had a lot of discussions about the pitfalls of race-based data collection, and I know you addressed one of them, which is making sure that it's a patient's self-identified race. I wonder if you can comment on any other kind of challenges in that space of race-based data collection, whether it be in terms of the data collection or unintended harm, I guess, from either the collection or analysis.
Yeah, and I think that's why Canada didn't collect it within the first place. The idea that we're all equal and everything is fine and that we should treat people equally was the reason why we shouldn't have the need to collect it. So there's this small number of downfalls where really have been turned into, that wasn't a downfall, that was the reason why we should collect it, because that wasn't true. So I don't think there now is very many reasons, very many downfalls. There's more so just the actual upsides of it. I know when Sonia Anand was doing some of the research, and Sonia and I had talked about this way back in the day, trying to find the South Asians within Canada for a big South Asian study, we mainly had to look at last name. And that's how you would find it, not because there was enough data, appropriate data. We should have had the data, but yeah, we had to look in the phone book and look at last name and figure that out. Now, of course, with the Black population, you can't do that because we have slave names that are British names, etc. So you can see that why we're in a new time and era where initially collecting it was seen as somewhat negative because it was racialized slavery data like property, but now it's very clear that it helps us to understand where the actual challenges are.
Excellent. Madeline, any other questions at the Miller?
Thanks very much. I don't see any others. Appreciate this excellent rounds again, Sean.
Thank you very much. I appreciate it.
Sean, can you see the question and answer box there?
Yeah, I can.
Martha Fulford's written 2 notes there that are fairly lengthy. I wonder if you just want to give them a quick scan and then maybe just summarize your thoughts.
Okay. Yes. Right. Yeah, so the idea of the disruption within school, and we haven't figured out how to fix that. So one of the questions is that there's a disruption within the school system due to COVID, and who does that affect the most? It affects the racialized groups the most. They're going to be far behind. So we're already at a starting point that is at a behind starting point, and you get pushed behind even further and further. It makes it worse and worse. So how do you catch up? How do we get to some degree of equity? And I don't really know the answer from a standpoint, but the first part was the recognition. So the fact that we've recognized it is important. The fact that we'll now have to push forward with education and keeping kids in school, keeping them motivated, keeping them active. So I think that's one of the more important aspects. And what I wanted to talk about was this idea of equity versus equality. People always say that, well, we just have to treat them equally. Like, let's make sure that all the races and all the groups of people get equal education, get access to education, treat them equally. There's nothing, equality and equity are completely different. If people are starting at 2 completely different points and you're treating them equal, they'll always be at 2 different points as they move along. Equity is an enhanced ability to try to get to a level where there is actual equality. And so you need equity, which means a different type of treatment. So if an Indigenous person walks into your office, you don't treat them equally to everybody else, because they're coming to you with the fact that they have a distrust of the system. They've had multiple challenges. Your treatment for the Indigenous person is at a level that's appropriate for the Indigenous person, which is a different level, which is a level that recognizes all their trauma and all their challenges. It's not equal, it's equitable. And that's a very important difference that people living with obesity walk into your practice. You don't treat them equally, you treat them equitably, which means a higher level or a different level, asking them appropriately. They're hurt, they're injured, and they're sad. So you have to address that in a way that is appropriate and compassionate. It's different treatment, it's equitable treatment.
Thanks, Sean. That's great. Go back to the obesity part of the discussion here. There's a bunch of questions on that as well. And so, as you know, I take GLP-1 agonists for obesity, and we've talked about that extensively in the past, and I've been doing it now for a number of years. A question, a very simple one, which I also am interested in. What's the effectiveness of GLP-1 agonists? I know that's a complicated answer.
Yeah, so the new GLP-1 analog that's come out to market, just approved on Thursday, can get up to about 15 to 17% weight loss on average. And then 1/3 of people are getting over 20% weight loss. That's in the surgical range. We've never seen a medication get to surgery levels of weight loss. That's a big deal. And so that's the first really big one to come onto the market. Within the next couple of years, there's going to be combination medications. And the good news is we've used these in diabetes. And so that means millions of patients have used them. So when we're looking at adverse effects, that's important because we've failed in the past with medications for weight management that have killed people. They've caused tachycardia and heart disease and bad things. So what we really need is safe medications, effective and safe. And so because millions of people use these medications, particularly in other disease states, we've got so much data and we have so much safety data and now effectiveness data. So we're looking at that high level of weight change. So there's no reason why somebody living with obesity should continue to live with obesity, particularly if you work with them in a compassionate way so they can get rid of their internalized bias.
One of the interesting observations that I've made is that, and we talked about this before we started today, and there's kind of an implicit bias in the insurance companies because they price the diabetes dose very differently than the obesity dose, and many drug plans, including McMaster's, cover the diabetes dose, but don't cover the obesity dose. I think implying that obesity is not as important a condition as diabetes is. I don't know if you comments on that.
Yeah, so I think the companies now are going to do their best to make the price ranges closer, diabetes and weight management, a price range. Now, the dose of the medication is higher so that they're on a per mil basis or milligram basis. That's why the price is actually higher, but because it wasn't, it was priced just on a volume level or a dose level. So now, but I think that they should try to pull it back to more closer dose pricing, but the pricing isn't ridiculous. It's not over the top. So the insurance companies are not covering it because of the price. They're not covering it because of the biases connected to it. Because if they can say that obesity is your problem, you should just go to a program, go do a thing, go pay for it, go exercise. Then they don't have to pay for the actual drug. So this is definitely not a bank breaker for them and going to cause a problem. It's just, if we don't have to pay for it, we won't. And we have enough support by people who will blame and shame the people living with obesity that we can continue this. This is going to end soon with advocacy, and insurance companies will start to pay for obesity-based medications.
Yeah, because it's a really interesting observation that for me personally, when I was on Saxenda, that if I was on the diabetes dose, it was $5.94 a month because it was covered, and if I wasn't, it was $600 a month. So it's nice to say that there's a per weight difference, but there's a gigantic difference in price because of the insurance vagaries. Greg Kern has asked two questions. Could you comment on weight loss in broad and direct and how they should work in practice? And then a related question that someone else asked was, when you have an inpatient who who for the first time you've had a discussion with them about their obesity, what is the appropriate management of that patient in 2021?
Great. I'll answer the second question first. So in hospital obesity management is very challenging. There's nothing you can do. It's a long-term chronic condition. What you can do is you can be good to them and be kind to them and talk to them about the fact that there is effective treatment, and their family doctor could actually know about effective treatment. And you could even write down the name of some of the medications as an outpatient. You should think about these things. You should think about weight loss surgery. If you qualify, and your family doctor can put an application in. We're doing lots of surgeries, and also cognitive behavioral therapy, knowing that you're important, knowing that you're valued, knowing that you're loved, knowing that you deserve care. That's what you want, and that will trigger the person to look for these effective cares. You deserve care with good medications, with good bariatric surgery, with good cognitive behavioral therapy. That's the job for you in the hospital. And then the dictation in the note for the family doctor should be, I address this. The patient wants to talk to you about it. They will move forward with it. So that's what I would do. I believe that family doctors can actually treat this. I don't believe that it needs to just be at a specialized center like my center. I believe that we have to get towards family medicine actually doing this. My centers will still be around for a long while, and people can go there, and the more challenging cases and etc. We'll definitely take them, but we're moving them back to the family doctor to try to get them to actually do it also. Next, Greg Kernew asked about the direct trial. The direct trial is a calorie deficit based diet trial in people with diabetes, and it showed remission of diabetes. So the intensity was weight loss causes remission of diabetes in a certain number of people. The weight loss was short-lived, and that's the unfortunate part. All diets are short-lived, and that ends up being the aspect that is a challenge. So we've proven that lower weight causes diabetes to get much, much better, but the challenge is keeping that weight down is very, very challenging. It didn't happen for everybody, obviously, and so as much as I like the direct trial, that I do think it has multiple flaws in the fact that it does not address the fact that that was a willpower short-term effect, and the people will get their diabetes back, and weight regain is horrible. It feels terrible for the person. They psychologically feel, you lose 60 pounds and you regain 80 pounds, that's a bad day for anybody. So don't put people on a trajectory where they lose a lot of weight only to regain it all. Put them in appropriate systems where they can keep weight off in an effective manner.
Yeah, thanks, Sean. And again, people who've known me for 20 years have watched me get thin and fat, and my peak to trough weight is 54 pounds. And I can tell you that gaining that weight back is horrible. All right, so two quick questions. We've only got a few minutes left. Clara Liu, whose name came up as one of the our learners who is working really hard on developing the race-based data collection at both hospitals, asks, Dr. Wharton, thanks for the amazing talk. In your experience collecting race and ethnicity data in the Wharton clinics, have you come across hesitancy from staff and patients in asking and reporting on race or ethnicity? And if so, could you share any strategies the clinic has found helpful in addressing this challenge?
Yeah, absolutely not. No hesitation by staff or by patients, and the patients fill it out. If a patient doesn't want to fill it out, the same way they don't want to fill out lots of other things, they just don't fill that out. But in general, 99% of the people are totally fine. They're like, thank you for finally getting this. I'm West Indian Black, identify as West Indian Black. I identify as South Asian. Thank you. So we don't see any problems. So, and when you do it, you just do it, and you'll see that it's not going to be a challenge. I don't know. We have great solutions to actually force it. I don't think we should. We should just leave it and let people identify if they want to. If they don't want to, they don't want to. Simple, easy peasy. We'll likely get in hospital systems maybe 80 to 90% and have no issues.
Thanks. And then the last question I'll ask is, Sonia is cloaking, Dr. Anand is cloaking herself as someone else because her name is Rachel Gerber that came up. Hi, Sean, what about GLP-1 in children starting in the USA?
Right. So the adolescent, so the FDA has approved liraglutide, a GLP-1 in adolescents between age 12 and 18. So obesity in childhood is a real problem, right? That's where we should really be working. Adults is nice, but really in children is where we really need to work. I don't know what that's going to look like. The treatment has been very challenging so far, but at least adolescents now, there is an approval for the use of medication. adolescents really struggling with obesity should get help, and that help should be at least the introduction of a medication along with CBT and love and kindness. So that love and kindness is a super important part of pediatric weight management. So the idea is, and what I should leave with everyone is that people living with obesity should not have to wait to get love when their weight is lower. That is what they usually think. I don't deserve love. I'll deserve love when my weight is lower. No, you deserve love now, right now at that highest weight. And that child deserves love right now. Don't force them to do specific things to get the weight down. So what, you can give them love then, give them love now, and give the adults love now. And that's my message for everyone at Christmas time.
Okay, thanks, Sean. That was really an outstanding set of rounds. I'm sure we'll get rave reviews from everybody. I really appreciate you taking the time, and also the obvious care and just like a lot of thought that you've put into those rounds. They were really impactful for two different populations of people who are, I think severely disadvantaged in our society. So thanks very much. And I will close rounds with that. Thank everyone for attending. These will be placed on our YouTube channel, hopefully within the next 72 hours or so. And I look forward to seeing everybody in 2022 for Chairs Grand Rounds. And I certainly hope that 2022 is a little less remarkable than 2021 and 2020 were. And Sean, do you want to have the last word?
No, I'm just excited. I had my filter, which was my Christmas filter here. I hope that everybody can see that. So happy Christmas to everybody. Yay.
Okay, thanks very much, everyone. Talk to you later. Bye.